Hi everybody. Today we are going to read a book, uh, Manual of Perioperative Care in Adult Cardiac Surgery, Robert Bojar. Uh, I don't know what's this, and I will close it as soon as possible. What we will discuss in this session is that body water distribution, effects of cardiopulmonary bypass and off-pump surgery on renal function, routine fluid management in the early postoperative period, prevention of acute kidney injury, postoperative oliguria and acute kidney injury, renal replacement therapy, hyperkalemia, hypokalemia, hypocalcemia, hypomagnesemia, metabolic acidosis, metabolic alkalosis, hyperglycemia, hypothyroidism, adrenal insufficiency, pituitary abnormalities. Here we go. Fluid management, renal, metabolic and endocrine problems. Perioperative renal function is a major determinant of both operative and long-term mortality following cardiac surgery. Even patients with mild renal dysfunction prior to surgery are more likely to experience acute kidney injury afterwards with a compromised short and long-term outcome. Therefore, it is essential to identify patients at high risk for developing postoperative acute kidney injury who may benefit from specific interventions aimed at optimizing renal function. This must be considered during cardiac catheterization procedures, during surgery and in the postoperative period, and include judicious fluid management, appropriate hemodynamic support, and use of adjunctive pharmacologic measures. Early aggressive use of renal replacement therapy may prove beneficial to patients with deteriorating renal function and may reduce the high mortality associated with postoperative acute kidney injury. A basic understanding of body water distribution, awareness of the factors that influence renal function and raise the risk of renal dysfunction, steps that can be taken to optimize renal perfusion, and early identification and treatment of incipient or established acute kidney injury are essential to optimize surgical outcomes. Body water distribution. Approximately 60% of the body weight, 50% in women, is water, with 2/3 of this residing in the intracellular space and 1/3 in the extracellular space. In the latter, 2/3 is in the interstitial space, the so-called surge space, and 1/3 constitutes the intravascular volume. Water moves freely among all three compartments and shifts so as to normalize serum osmolality, which generally reflects the serum sodium concentration. Sodium moves freely between the intravascular and interstitial spaces, but doesn't move passively into cells. Therefore, if a patient receives a hypotonic sodium load 0.55% saline, which would lower the serum osmolality and sodium concentration, water will move from the extracellular space into the intracellular space to normalize these values. The presence of a low serum sodium concentration in the postoperative patient usually indicates total body water overload. Starling's law governs the influence of hydrostatic and oncotic pressures on fluid shifts. The primary determinant of oncotic pressure is serum protein, which remains within the intravascular space. Elevated hydrostatic pressure, increased pulmonary capillary wedge pressure, or lower intravascular colloid oncotic pressure, lower serum albumin, will shift fluid from the intravascular space into the interstitial space, contributing to lung and tissue edema. Conversely, raising the intravascular oncotic pressure with colloid 25% albumin, will tend to draw fluid from the lung interstitium back into the intravascular space. It should be kept in mind that Starling's law describes fluid shifts in the absence of abnormalities in membrane integrity. However, extracorporeal circulation is associated with a systemic inflammatory response marked by increased membrane permeability and a transient capillary leak. When this leak is present, administered fluid will shift more readily into the interstitial space. Clinically, one may note impaired oxygenation and decreased pulmonary compliance, higher peak pressures on the ventilator associated with increased extravascular lung water. This can produce the picture of non-cardiogenic pulmonary edema. Expansion of the interstitial space and hyponatremia may also contribute to cerebral edema, mental obtundation, hepatic congestion, jaundice, and splanchnic congestion, ileus. Effects of cardiopulmonary bypass and off-pump surgery on renal function. Use of extracorporeal circulation is associated with subtle effects on renal function, with an increase in virtually all kidney-specific proteins that are markers for tubular damage. Some of these, such as neutrophil, gelatinase-associated lipocalin, cystatin C, kidney injury molecule 1, and interleukin 18, have been shown to be early biomarkers of acute kidney injury that correlate with the severity and duration of acute kidney injury. However, very few centers routinely evaluate renal function other than by serum creatinine levels, and in the vast majority of cases, there is little significance to subtle changes in tubular function as long as the kidneys produce a satisfactory urine output with or without diuretics, with minimal change in the serum creatinine. The influence of extracorporeal circulation on renal function is multifactorial. Extracorporeal circulation involves non-pulsative perfusion with hemodulation and variable degrees of hypothermia. It produces elevated levels of hormones that affect vascular tone, renal blood flow, glomerular filtration rate, filtration fraction, and electrolyte balance. It also evokes an inflammatory response with activation of complement and neutrophils, release of cytokines, and production of oxygen-free radicals. Thus, there are a number of factors that influence renal function, including those that influence renal blood flow and trigger renal ischemia and tubular insults associated with the inflammatory response. In general, extracorporeal circulation is accompanied by an increase in glomerular filtration rate, renal blood flow with increased osmolar clearance and fractional excretion of sodium and potassium. Cardiopulmonary bypass results in activation of the renin-aldosterone system, promoting sodium retention and potassium excretion. With elevation of angiotensin II levels, increasing renal vasoconstriction and sodium retention, it also activates the sympathoadrenal axis, elevating levels of epinephrine and norepinephrine, increasing systemic resistance, plasma-free cortisol after bypass, promoting sodium retention and potassium excretion, and vasopressin levels, increasing renal vascular resistance. Release of vasodilatory mediators, including nitric oxide and prostacyclin, transiently impairs solute reabsorption. Other vasoactive substances released during cardiopulmonary bypass include complement, kallikrein, and bradykinin, which alter vascular tone and contribute to the generalized inflammatory response that increases capillary permeability. Hypothermia. Hypothermia decreases renal cortical blood flow by producing vasoconstriction.